Fuck. Hi guys, we're having some issues with getting everybody on. Some people, the link isn't working, so give us just a few more minutes. Sorry about that.
Patrick, we just have a couple other people trying to log on, but we probably could get going.
I think I'm here finally. Hello,
Okay.
everyone. So this is Patrick Jones calling from sunny Spokane, and I think we should get started. I am apologetic that I came so late, but I've been trying to get on for the last 15 minutes, and finally got some help from Stacy that worked, and I'm good to go.
Sorry for anybody that have issues logging on. I apologize for that. We'll get these settings fixed so this doesn't happen again.
Not a problem. I had a few wrong passwords. So as you can see, today's agenda is about two things. The Community Health Worker Initiative that we have been involved in at GCACH for quite a while. And then another initiative that we have also been involved with in a couple different places. And we certainly want to learn from Walla, where this has been going on for a while, and elsewhere. And that will round out the rest of the meeting. I've got a couple other remarks, but before we start, is there anybody on the call who would like to give the land acknowledgement to recognize just where we are at here in Eastern Washington and South Central Washington? Just need one volunteer to read a brief, heartfelt few sentences that talk about our consideration for the tribes of Washington. Anybody?
This is Kelly. I can go ahead.
Go ahead, Kelly. Thank you.
we should take a moment to acknowledge that the land on which we live, work, and play contain the archaeological resources and tangible evidence of Indigenous peoples. It is the historic homelands of the Yakima, Wanapum, Nez Perce, Colville, and Umatilla people who remain committed stewards of this land, cherishing it and protecting it as instructed by elders through generations. We are honored and grateful to be here today on the traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
Thank you, Kelly, and what a beautiful place we live in. All right, shall we shove on? You can see the first, well, here are two of our speakers. Becky Betts from Providence St. Mary and Walla Walla is going to be talking to community health workers. Cody, as a community paramedic, Kobe Main, also from Walla Walla, will be talking about the experience that his department has had with community paramedics over the years. And then just cursor forward just a little bit, please. And we'll get, and then here's some of the folks on our panel. Maria Remington, also from Providence, Rachel Dickinson from Providence, and Brian Delano from Providence, I assume Walla Walla. So before we start, I just want to say, for those of you who know a little bit about me, I'm a numbers guy, and I wanted to see just what the state economy is saying, or the state labor economists are saying about community health workers. I went back to 2005 and looked at all the occupations that existed in the state of Washington in that year, and not one line mentioned community health workers. I then went on to 2010 and looked also in vain for this concept, this occupation of community health workers. I then turned to the most present data set that we have, which is from 2021. And all of a sudden we see community health workers statewide numbering 3,100 plus. So this has been a dramatic rise of a profession that just a few short years ago didn't exist. And I think we're all the better because it does exist. So we're going to explore just what that has meant to Walla Walla for sure, and hopefully to some of your experiences in your communities through the Q&A period. So I think the order of the agenda is we're going to start with Becky. Is that correct? Becky, are you there?
Becky, you might be, oh, there
Yeah.
we go.
Are you muted, Becky?
I'm such a professional. Yeah, go ahead and start off with a bang, muted. Thank you, Patrick. I am here and I have a brief slide deck I'd like to share, just a kind of an overview of our Walla Walla Community Health Worker Program. And then I'm really going to get out of the way and I'll let Brian and Rachel and Maria speak for a moment. I am so happy to be here and I am going to share my screen. Oh, can someone?
Yep, go for it.
Okay. All right, what do you guys see?
We see a slide of 3 happy people.
All right, no notes, right?
No,
I don't want to give all my secrets away. All right, thank you. Thank you again for having me. I'm Becky Betts. I'm the Director of Population Health Integration and Case Management Continuum for Providence, Southeast Washington, hailing out of Walla Walla. I always start off my presentations with this beautiful churning water, and my favorite quote by the late and great Desmond Tutu: there comes a point where we need to stop pulling people out of the river. We need to go upstream and find out why they're falling in. I think there is no greater quote that embodies what population health is and what we're doing in Walla Walla and throughout your communities. And I just absolutely love the quote, because I think of, my work in 30 years as a nurse, and many of it at the bedside and the emergency room and taking care of people, and the frustrations of having the same people come back over and over and over and over again, and the tug of wars that we get in and day out, and the power differentials and the lecturing, and why can't you just take your medicine the right way, and why don't you adhere to a plant-based diet, and you were supposed to go see your diabetic educator, and why didn't you pick up your prescriptions, why? And then the moment when you realize that, oh wait, you don't have a car, you live under a tarp, you get out all of your meals at a shelter, you work 12 hours in a field, you take care of a special needs child and an elderly mom, your income is $600 a month, you can't read. It was then I really began to understand and fully appreciate social determinants of health, and I could not sit still. So I really embrace this calling for upstream work. And I am on fire for a community-based workforce. And I really want to give a lot of credit to our Greater Columbia ACH, who really have chosen workforce development and as their cornerstone priority. Our communities are stronger because of your leadership in this space. And I look at the participant list and I feel largely like I'm speaking to the choir. Many of you have seasoned community health worker programs, and I really want to thank you for pioneering this effort and taking my phone calls and coaching and mentoring me. So I'm a student. I'm a student at WSU, and a lot of my courses are around design thinking. And I always ask these questions as I launch particularly in the space of Medicaid transformation, is what can we do? What is a good program? What if we did this, and what works and what wows particularly? And so it's kind of the last thing I ask myself before I fall asleep. Like, what can we do to change the paradigm of healthcare? How do we make a difference in avoidable ED use and healthcare expenditure and human treasure and trove? What can we do? What can we do? I constantly ask that question. And the solution, obviously, is rooted. Why I'm here today is to talk about community health workers. Just as a recap, a community health worker is a member of the community working within a healthcare system. They reach our patients where they live, eat, play, pray, and worship. They are our frontline agents of change, helping reduce health disparities in the communities they serve. The next sentence is earth-shattering. These caregivers are not tethered to bricks and mortar. They are boots on the ground. And that has been a game changer. And promotore de salud, which I'll introduce you momentarily, is really the definition directly as a promoter of health. And it is a bilingual, bicultural community health worker. So back in 2019, when I took helm of population health and had to sell this to my executives that I really wanted a community health worker program to pilot in Walla Walla. This is really what my executive summary points were. We know that social determinants of health, about 80% account for health outcomes. Only about 20% are medical care, your face-to-face with your doctor, your genetic makeup. And those social determinants you really can't remedy during an ED or an inpatient encounter. It's just too hard. You can't fix homelessness and poverty and food insecurity during an inpatient admission. So we needed help. We needed help outside the walls of the hospital. We know that ailments and untreated disease generate much heavier downstream costs. So we're going to pay for it. We can pay for it now, or we can pay for it up way downstream later. And this is what I promised them, that we would see a reduction in avoidable ED visits, decreased burden on EMS, reduced length of stay, reduced no-show rates, increased penetration and adherence to behavioral health treatment, and lives would be happier in Walla Walla. So I made a big, bold promise and twisted their arms, and they finally said yes. And we got our first 2 community health workers. We hired and interviewed, onboarded as COVID was wreaking havoc on our communities in spring of 2020. This is Brian and Rachel, and whatever they go and do in life, they will forever have the distinction as being the first Providence hired caregivers in all of Washington State, our community health workers. So, and boy, have they ever delivered and hit it out of the ballpark. Just a brief overview of the Walla Walla program. I have quotes peppered throughout the slide deck, and if you totally tune me out, please take the time to read the boxes. I can guarantee the quotes will put you in a really happy mood. Those are direct quotes from patients that our community health workers serve and take care of every day. So we didn't have a playbook for this. There wasn't something we could grab off a shelf. We just had to invent this as we go. But I knew that the work had to be relationship based, that we couldn't get anywhere if we didn't develop a relationship with the people we served. And it had to be healing, and it had to be authentic and real. And as a lifelong resident of the Walla Walla Valley, we are rich in nonprofits and we are rich in community service organization, but care continues to be fragmented and siloed. And I really wanted our community health workers to be that eye in the sky, really get at that 30,000 foot view and put the pieces together so they can identify where their patients get their mental health, where they get their food, where they get their healthcare, and put all the pieces together, all those fragmented pieces, and look at that whole person care through that whole person lens. And have that beauty of being tied to a healthcare system where they can be plugged in and a partnership with a nurse and can get to a provider really quickly. Of course, social determinants of health focus because we know that affects the health outcomes. And I wanted them to constantly upstream and round in the community and be very visual. And boy, as everything was shuttered during times of COVID, there were times they were the only ones on the street. And so they made their mark pretty early. And we wanted to be a collegial partner. This is heavy lifting. We cannot do this alone. Providence does not have any interest to lead in this space, but we want to partner with our community partners and hold their hands. There's more than enough work to go around, and it takes all of us. Our community health workers are detectives, and they're nimble and they're mobile and they're sleuth and they're navigational, and they are our eyes and ears, and they inform us really what's going on in this patient's life so we can make those healthcare decisions and present the patient with a shared decision-making tool based on what the nuances of what's happening in their home and their life, not a cookie cutter, what a heart failure treatment looks like, but based on an individual care plan. So then came COVID, right? And the disparate, devastating effect it had on our Latinx communities, and the death and toil as we watched, particularly, in our healthcare system, in our hospitals, Latino men and women dying in our ICUs. And we knew we needed to do something. And we were having such success with our English-speaking community health workers, it made sense that we needed we might be able to use a bilingual community health worker to build those bridges, to be a trusted voice, to build those relationships. And about that time, we were approached by a business, Vital Wines. Vital Wines is a nonprofit winery in Walla Walla. 100% of their profits go to ensure that winery and vineyard workers are valued and have access to healthcare. So this was just a real natural partnership. And they, when they approached us for a potential partnership, the natural answer was yes. So Maria is a co-branded employee of Providence, but position is supported by Vital Wines. And she was hired last fall as our first promotora. And these pictures are really an example of the power of promotora. On the left is our population health and community program manager, pharmacist Amanda Johnson at Valley Lindo, our migrant neighborhood, just last Saturday, giving vaccinations. And I, along with many others in the County have tried for over a year to bring a vaccination clinic to this neighborhood to no avail. And it was really Maria who organized this most amazing resource fair that we were able to go last Saturday. But that is the power. I could not do that. We needed Maria to broker that. And then of course on the right, a rainy day in October, delivering blood pressure cuffs and heart health education right out to the vineyards, right out to the people picking grapes, because this is where healthcare happens and the magic happens. And moving along, just what are our success metrics? I'll just, quickly, exactly what I said. We are seeing the fruit yielded. And this is really mission-driven work. This is hard work. This is not for the faint of heart, but we are absolutely seeing the data is this is what is going to get us out of this mess. This is a community-based workforce, is improving health outcomes and decreasing healthcare expenditures. I had the pleasure of speaking with the Healthcare Authority a few weeks ago, and I said that very loud and clear. An example of that data, and Rachel's going to talk about Tammy in a moment, but this is Rachel's client, Tammy, December of 2020, this 47-year-old, mild developmental delay, seizure disorder, had some strife in her life. January of 2021, look at those 19 avoidable emergency department visits. We charged her managed Medicaid plan, $45,000. February 1st, we deployed Rachel to build a healing, authentic relationship with Tammy. The first 2 weeks of February, still 7 ED visits, but better. Rachel worked like just a whirling dervish and got Tammy placed in an adult family home with supports mid-February. And look at that. 2 emergency visits and 1 annual wellness visit in the last 368 days. Now, it hasn't stopped. Rachel continues to have a relationship with Tammy, and she can talk more about that. But utilization the first 45 days of 2021 was 26 compared to what we're at now. That is the power of a community health worker. Appreciative inquiry. I think this program works because humans are not a problem to be solved. They are a mystery to be embraced. And I really love this quote. Rachel, don't stop looking under bridges and walking the trails. People hide there that need a friendly face like yours to cross their paths. And our community health workers really appreciate and the value of the people they're working with. They're not throwaway people. They really see the value and they see what's right with the situation, not what's wrong with the situation. And I'll give you an example. You can look at these pictures and there's a lot with what's wrong perhaps, but our community health workers see what's right and they see the light and the love and where to go. The gentleman with the dog, boy, our homeless population often have pets and they're truly beloved. That's the in, that's the leverage point. They bring the dog food, they bring the pet toys. So they see what's right with the picture and they go from there. On the bottom left, a couple living in their car. There's a lot wrong with that picture, but there's some right. They have some shelter and the lady's reading the book. There's some literacy. So they look to see what's right with the picture and they go from there. And then of course, our beloved Michelle, I was an actual patient. What's right is she's a mom and leveraging that beautiful relationship between mother and son. Which is Brian facilitated and is such a heartwarming story. I'm going to cry if I tell any more about it. But and finally, really what has made our program successful, we hire for attitude, we train for skill. You have to have the attitude. We can train them, but you got to have that spark in your eyes. You love them and you build them up, give them every opportunity and feed their passion, exposure. I expect great things. I expect our community health workers to be running Providence one day as a healthcare system, and any one of them are more than talented and able to do so. But and they're integral and a valued part of their team. They have the loudest voice at the table because they have the greatest insight. We are a lonely, lonely, lonely society, and 39% of Americans state they don't feel close to anybody And that was a 2021 data. And by carving out healing authentic relationships, in some instances, the very first one a patient has ever had in their life, they are mitigating loneliness and mental health sequelae. And we know that unmet psychosocial needs, drivers of depression and anxiety, just manifest those physical, and healthcare issues. So I think that the sum of their parts are amazing. And we celebrate everything. Like I said, this is heavy work, but the smallest of wins get celebrated. It keeps our cups full for when things aren't going well. And this is a picture of I was giving Brian his first manicure. Get it, like man a cure. And this was on our population health's second birthday party. So, but we do celebrate everything, and we have to because they're doing such amazing work. And I am going to hand it over to our team because they're magic, and I just kind of stay in the background and cheer them on. So Patrick, can we have our community health worker speak, or what? How would you like the cadence to go? Quick, Sherry.
Yeah, let's have the panel speak, Becky, and then make you available for a Q&A session before the break. All four of you. How's that? So is there a set of PowerPoints from Maria and Rachel and Brian, or are we going to just do
They're going to wing it. They're going to wing it. Virtual panel. Yep.
So
I think
Maria,
they're going to come.
Are you up first? I see your smiling face there. Are you going to lead off?
Okay, this is me, Maria.
Okay.
Okay, so I'm from Ecuador. I came here like 20 years ago. When I stepped in Walla, I fell in love with the community, and especially with the Hispanic community. As you know, when I came here 20 years ago, I didn't know how to speak English. So 20 years later, I'm speaking a little bit English, a little bit better with a lot of accent. But as you know, here in Walla, we have agricultural workers are essential for part of our local community and economy. Often, they do not have access to reliable and affordable healthcare service. The Pub Health, this team that I work with right now, and Vital, and I provide on the ground access to the health education and resources, including COVID-19 education, vaccines, like Becky said last Saturday. We have success fair resource with a lot of help. Of course, Becky and Amanda Johnson, they were over there supporting me and helping me with this. And we help our people disease management and helping to connect individuals to essential healthcare. We are building trust, we are building community. We just starting, but it's a lot of work to do. So I organize like every month workshops, education workshops. So we are trying to prevent, we are trying to build, like I said, trust and community. And when I want to tell you, when I saw this position, my heart was beating because it's the passion that I have to work with the Hispanic community here. So I'm following my passion. I'm glad to be here. I'm glad to be part of the team with Becky and Amanda Johnson and all my team here. They inspire me every day with the job that you see. They inspire me to serve and do my best every day. Thank you for having me, and have a great day.
Okay, I hope people will be able to have some questions for Maria, but for now, are we going to Rachel? Are you next, or is it Brian?
Yeah, I could go. Hi there, I'm Rachel. So I kind of wanted to touch base more about the patient that Becky had presented, Tammy, and just kind of tell you more about behind the scenes of how that kind of looked. So with Tammy's high ER visits, meeting Tammy, we found out that she lived with a roommate and had about 40 hours a month of caregiving services, but clearly wasn't enough. We pushed to get her more caregiving hours, but still became clear that she was not being fully able to care for herself. After getting to know Tammy more and more, we found out she was pushing her life alert button every time she had a seizure or felt one coming on, because that's what she thought she was supposed to do. which most of her seizures were brought on by stress. Getting patient proper education from her neurologist and discussing her wand for her pacemaker was our first attempt, since she had never not only used it, but never even took it out of the box due to lack of education and understanding. With patient being a vulnerable adult, it put her at high risk of being abused and taken advantage of. Soon finding out she was being taken advantage of physically, emotionally, and financially, which played a huge part in her overall stress. So getting patient out of that toxic environment was top priority. We were able to apply for services through aging long-term care and assist patient with getting placed in an adult family home. As well as assisting and providing emotional support with myself and a nurse case manager, we were able to help patient get a restraining order for a vulnerable adult against the person who was taking advantage of her. The day we got the okay to move patient to the facility, I got boxes and helped her pack all her stuff. Does this happen every day? Probably not. But part of being a community health worker, you have to be versatile, flexible, and creative. In most cases, our patients' clients do not have the support of family or friends. Getting patient into the adult family home was the easy part. But being able to reassure the owners, managers, staff that we weren't just dumping them into their laps was ongoing and still continues to be. I would check in on patient 2 to 3 times a week for the first few months until patient started settling in, and then it became more of a monthly check-in. The owner of the facility still has my number and still reaches out to me if she needs anything. All we did was show up, listen, found out what was really going on, and helped her get set up in a place where she was going to be safe, secure, and have her needs met where they were not being met on her own. We do our best to provide support, stability, and trust with our patients. The more they trust you, the more they tell you, the more you can help them. Being a community health worker feeds my soul, and I feel like this is my purpose in life and wouldn't want to be doing anything else. And that's pretty much a behind the scenes of a day of a community health worker, and kind of sums it up.
All right. That's it for now, Rachel?
That's it. Thank you, guys.
Okay. Then we'll move on over to Brian. And I see he's popped up on the screen. So Brian, the floor is
my name
yours.
is Brian. Becky Betts had asked me to share a patient win, one that shows the importance of a healing, authentic relationship. I could tell you a story or two about the individuals that I've helped get sober, housed, employed, or the healthcare they most desperately need. But my patient success started 20 plus years ago where I grew up in a small rural community, and I witnessed and experienced many of the things my patients are going through. I was raised by my mother and my grandparents, my grandfather playing an important role in my life. He was the chief of police and an active member of the community. He instilled in me the values I carry with me today: to treat people with compassion, respect, dignity, and empathy. And with that being said, the patients we work with at Population Health, many of them struggle with substance abuse, mental illness, and food insecurities, to name a few, and add a chronic illness on top of that. Lots of these individuals are trying to navigate these scary waters by themselves and deal with these hardships on their own until a community health worker comes into their life. And we help these people. We help and empower these people to give them the strength to overcome their fears, to navigate these scary waters and not do it alone. Because as a community health worker, we can provide support our patients need, along with walking beside them as they do this. We help provide, these individuals are missing tools in their toolbox, and we help provide them the tools they need to overcome their hardships. And I'm reminded of my successes every day by the texts and the phone calls I get saying, "You are my earth angel. You tend to show up when I need you the most," and things of that nature. As a community health worker, we carry around 1 million pounds of feathers, 1,000 secrets of shame, abuse, neglect, and embarrassment, and the hardships they have faced and the struggles that come along with them. And all these play an important role in how we do our work, because this allows us to help them navigate not only healthcare, but mental health, housing, substance abuse help, and we help get them a support system they were lacking to begin with, so they can handle these things on their own when we are out of their life. We have had many successes, and I'm very proud to be part of this team. I have people that just want to make our community better so we can thrive, and everybody has the opportunity to be a part of it. And that's just a short of what we do. We are somebody, because a lot of these people have nobody.
All right. Thank you, Brian. Thank you all. So I don't see any questions in the chat yet. So while you're thinking about questions to ask the four of the Walla Wallans on the line, I've got a question for you. How do you find the people you help? Do they come to you? You go to them? How does that work? Anybody want to take a stab at that one?
We get referrals from every department within the hospital, but there are times when we find them on the street, I'm not afraid to ask somebody if I see them struggling with trying to find help. I will stop and help them, hand them my business card, and they become my patient. I have picked people up from the gas station just randomly, stopped on the side of the road, or just found them sleeping in a park and offered help. And sometimes those people get housed, get sober, and become functioning members of our community.
Okay. Maria
Becky?
or Rachel, how do you find the people you help?
Okay, for me, all the time in the community, I find them in the field, like you said, like Becky showed the picture. So I like to go to the fields. I like to go over there. Churches, I like to go, of course, outside or sometimes inside the pens. I like to go where they at. For example, if they have a parties in the parks, or when the city have events, I like to go over there. I meet them at the grocery store. So it's like every time I'm working, when I see somebody, I ask them, I give them my business cards. So that's how I try to outreach to them. And then of course, referrals too.
Okay, thank you. And Rachel, how do you find the people you help?
I think, like Brian said, we do receive a lot of referrals, but I think more than anything, word of mouth and a lot of community partnerships, they refer a lot of people to us, and just even the schools or anyone are calling us now and be like, well, can you help get this student to this appointment? I mean, we want to just fill in the gaps everywhere. So it kind of just depends. I would say I could walk outside right now and someone, we might find a patient. You just never know.
Okay. Then in the chat box, here's a question for you, Becky. Can you explain how this is all working through Providence? Just a bit of nuts and bolts of the program.
Yeah, no, I feel tremendously grateful that you know, there's those silver linings of COVID, and we as a healthcare system put a big stake in the ground that health equity matters. And part of health equity is that we recognize that we don't have a equal playing field for health access. And with that in tandem is the recognition that a community-based workforce is something that a tool that can help level that playing field. So from Lubbock, Texas to Anchorage, Alaska, you know, Providence is a third largest healthcare system. We cannot get community health workers fast enough. So, you know, it started with Rachel and Brian in Washington State, and, you know, they've had community health workers in California, but I know that now everywhere, every service area, because of the recognition that these social determinants are such huge drivers of health outcomes, we're getting them everywhere. So this is, I think that we're at a paradigm shift that we know that health, so much of health occurs outside of the brick and mortar, outside of appointments. And it's a time to be incredibly creative, that medicine is not always slewed out of a bottle. Like Cody will say, we have to be really individual and creative on how we take care of patients. And so we've had a wide berth, and largely, honestly, it's been because of our relationship with our Greater Columbia ACH through Medicaid practice transformation. We've had a green light to do some amazing creative things, and the community health worker launch was one of them. And fortunately, it's had some very good results and will continue to grow. We have now 7 community health workers, promotores. So this is only going to get bigger. And I will never work for a healthcare system or agency that does not have a community-based workforce, period.
And also, Becky, this is Ann. Can you talk about how they work with the case manager, and that's kind of how one way that the patients are?
Yeah, I think every agency or organization would be better. It would behoove them to have a community-based workforce or community health worker out and about. But it's been incredibly powerful to be linked to a healthcare system where we have set up a dyad. So they are linked to an RN, a case manager dyad, where they have that, they team conference. And on our team, we also have the benefit of having MSW, our social worker. Melissa's on the call today, and Amanda, our manager, and our pharmacist. So we do have a wraparound service team, but each one of them have a nurse that is on speed dial. So if any one of their clients or patients have a medical issue, they don't have to go through that front door of the receptionist, or they can fast track and get to a provider pretty darn quick. Or if there's a medical issue or a medication issue, it's been really powerful. So we feel like we have our patients pretty locked in.
Okay.
Thank you.
Thank you, Becky. Question for any one of you. What about veterans? Are they eligible for this, or do you work with the VA to sort of help them have the VA do the work?
No, we anybody. And, in fact, probably over half of our caseload are patients that are not attributed to Providence, a medical group. So I get tired of people think this is their patient or this is the FAQ patient. You know what? They belong to the community. So, especially the patients that don't belong everywhere, they belong to all of us. So we are the only acute care hospital in ED in a very large catchment area. And so, we take care of all. So we have patients that belong to our FQHC, Walla Clinic. We take care of everybody and anybody. And if they are veterans, that's the sleuthing and the navigation and investigative work. So we do not want to duplicate work, but Rachel and Brian and Marie are very good about, if they get a referral, the first thing they do is making sure that who the person belongs to, and link them up to a case manager, or if they're eligible for a variety of services, get them linked in. So these guys are a master walking encyclopedia of resources throughout the South Central region. And we definitely don't want to duplicate, but complement.
Okay, thank you. I've got a question for Maria in the chat, and this is a question, Maria, about your vineyard work. How did that start? How's it going now? What do you anticipate doing in the future?
Okay, so I started in September, so the first month, and in 6 months I'm working in this position. In October, I went to visit the wineries, and I knew they are like a little bit skeptical because they didn't know me, and I was representing Providence, and they have in their mind Providence is expensive place, I don't belong. And they didn't believe it. So it was a little bit hard. That's why I came up with the idea, do workshops every month. So I invite them because I have texts, I have telephone numbers, and have some names that I was able to get because they were skeptical. And then that's why I came up with the idea, I need to do workshops so that way they know the Providence. We are here for helping them. And then a lot of people, they don't know that we have the mammograms. So I try to explain the mammograms. I'm trying to explain what's the COVID. We have COVID vaccines. I can help with the registrations. A lot of people, they don't have internet. They don't know how to navigate. So I started helping them, building the trust, building the community. So it's a work that just as I started. So I'm trying to go where the neighborhoods, where they are living. So I start to going over there with the fair resources. So that way we can build that trust. That is very important because they have some misconceptions about Providence. It's expensive. Nobody speaks English, Spanish over there. Now with me, being a bridge to them and telling them, we are here to help you. We are here. I have these resources for Walla is beautiful. Like Becky said, we have a lot of nonprofit organizations but they don't know. So we are trying to build that bridge to them. And it's a job that it keeps going. It's just we are starting. So hopefully I can answer those questions.
You know, Dr. Jones, we lost 3 women in their 30s in that Valley Lindo neighborhood that we went to last Saturday. We lost three mothers in their 30s to breast cancer in 2019. They were all field workers. And I am so proud of Maria because in the last few months, she has brought dozens of women in for free mammograms to Providence, women who are long overdue for mammogram who've never had one. And I just think of those screening mammograms of the lives that Maria could potentially be saving. And but we need Maria because this is not going to happen by a brochure or an advertisement. We need a promotora going to where people are as a trusted voice to bring them into healthcare to, again, address those disparities.
Very good.
Thank you.
I'm looking for more questions in the chat box, so come on now.
Suzanne,
There's got to be a lot of hands up there. So who's that? Is that Diane? Are you talking?
Yeah, so Suzanne Swadler from HCA has a question.
Oh, Suzanne, I didn't see your question. I'm sorry.
That's okay. I'm raising my hand so you wouldn't see me in the chat box. I did put something in the chat box. I think that the piece I put in the chat box, Becky, you answered well when you talked about how your team works as part of the team in the hospital. That's very exciting. I'm going to ask just a quick follow-up question to that. And then my question is really at this point, how do you manage the rural nature of the communities that you're dealing with and the spread that needs to be handled by the CHWs? It's often cited when we talk about CHWs in rural communities that that's a barrier to starting a practice or running a CHW program because it's not, or lack of energy and empathy and commitment to the community. It's how do we get that logistically managed? So the first follow-up question really quick is, it's really exciting to hear how the people are connected to Prov. How do you do that connection with the other referrers that you have, since I know you have a number of those? And do you have a connection with other entities that are serving these clients so that we make sure people are getting to the things they need in a really efficient way?
It's a great question, and that's probably maybe the next iteration or evolution of the program. So, and I'm hoping that maybe our Greater Columbia can be the convener of conveners. Though I want to make sure that, you know, when I think about our South Central region, Asotin and Garfield and Columbia, and why there may be, you know, the beginnings or community health workers or programs, but I would love to make sure that what we're building in Walla Walla or replicating, or what they have very strong community health workers in Benton Franklin and Yakima, but I want to make sure in the purview of health equity that all of our rural communities have access, because this is exactly the model of healthcare that really resonates with rural Washington, meeting people where they're at. I mean, it checks a lot of boxes. So I'm really hoping that our Greater Columbia, and I know that this passion around Diane and workforce development and yeah, to be continued, I guess would be the best question. And we're working on it. We're expanding our geographic. I can tell you these guys, I approve their mileage every month, and boy, they're stacking up some mileage on their rigs. I'm hundreds of miles. I mean, they're in Starbuck and Prescott, and they're in the willy-nillys and the boonies, and they go everywhere. During the height of COVID, I will tell you, they delivered at times 6 to 8 to 10 food boxes to doorsteps every single day, and it didn't matter. They're better than the mailman. I mean, they will deliver in sleet and ice and snow and floods. Nothing stops these guys.
Thank you very much. I appreciate the answer and the connection. It's good to hear. Thank you for all you're doing.
It's great to hear. So this is a question for the three, Maria, Rachel, and Brian. You may or may not know that GCACH has really put some money and muscle behind an educational development of community health workers. And this is sort of novel territory in terms of our higher ed area. And if you were to design a training program for what you do as community health workers, what would be a couple things that you'd recommend to the teachers or the administrators of such a program? So I'll start with you, Maria, and then we'll go to Rachel, and then we'll go to Brian. What's important in learning to become a community health worker?
First of all, is if showing if they have a passion. I think that, you know, if as a community health worker, they need to be sure they love to work with people in those conditions where they are. Sometimes they're very sick, sometimes they have addictions, sometimes they don't know how to read, sometimes they don't know how to navigate the system. So they need to tell the people they follow their passion. And second, they need to be very humble, you know, and they need to be bicultural, especially if, you know, some people, they need to understand the immigration situation too. So it's very delicate. So the immigration situation, especially with the Hispanic community, is need to be the key over there, and be compassionate and have a big heart. So yeah.
Thank you. Compassionate and humble. So characteristic traits, maybe these can be taught, maybe they can't, but you would recommend that that would be a sort of a screening device for people trying to enter the program, is they have to check those two boxes, huh? Okay, so Rachel, what would you recommend to prospective teachers of community health workers going forward?
So I think kind of summing up what Maria said is a lot of, I feel like people with lived in kind of experience of being able to relate and connect a little bit better, obviously can just ask that of anyone, but I feel like they're going to be it's almost like a better match. And if not, then at least really prepare them in the very beginnings, not later on down the road, but making sure they have the motivational interviewing and the de-escalation training and the trauma-informed care, just making sure they have that maybe throughout the initiative of the CHW training, just so that way if they've never dealt with that kind of stuff before, it's not a big surprise and they don't know how to handle certain situations, because you just never know what you're going to get.
Mm-hmm. Okay, very good. And Brian, what are your thoughts about what's needed to produce clones of yourselves?
Rachel touched on some of the important and good ones. I would add, we do have a great mental health first aid for both adults and youth instructor here in Walla Walla. She does a great job. I would also, any bit of education you can get is important. We do and deal with so many different things that I'm not opposed to learning something new, whether it be medical or social work kind of stuff, just because they both go hand in hand and it benefits you in the long run when you're out in the field and you know the best way to address that person, because we're meeting them where they're at. So it's different. Every person's different.
Okay.
Anything to do with insurance, that's where I lack. I don't know any insurance information. It's always an embarrassing call to call Medicare or DSHS for Apple Health and try to help my patients navigate that when I'm lacking in education and insurance stuff.
Okay, yeah, insurance is definitely pretty daunting I think for all of us. That's a good point. Does anybody from GCACH want to respond to that as well? I don't know to what degree.
Yeah, so I will.
We're involved in setting up the curriculum, but you know, we want to be able to prepare future community health workers to the best degree possible. So what's going on there?
Yeah, so this is Diane Halo, and I have been working on this community health worker program that GCACH has started. And, you know, to be honest, when I first heard Becky, she came to one of our staff meetings and explained how their community health worker was set up and how they're working and the connection with the health system. And it just lit a fire under me. And that is exactly what I want for our organizations that are providing community health workers through our program, is that connection and that resource and all of that. So we actually tailored our program around what Becky has started there. And I know that a lot of, you know, our federally qualified health systems already have community health workers, and they work really well with those systems. But there's so many the need for community health workers in our rural counties is the key. And, hopefully we'll be able to secure some grant funding that will be able to spread and scale this even more in the near future. We have developed a pretty heavy training program. Brisa and I are in the process of getting those set up. And so, yeah, the main focus that we were asked to help with was around behavioral health. And so we've done trauma-informed care, motivational interviewing, mental health first aid. We've done a training for the supervisors that are actually managing these community health workers. And then coming up, we have definitely, there's some on communication. There's going to be one around making sure you as a community health worker is safe in the work that you're doing. And yeah, so it's just going to have a vast majority of trainings that will start happening. So we're hoping to start having a training for the community health workers. And it doesn't even have to be the community health workers just in our program that we're funding. It's welcome to any community health worker within our counties that we serve. And so they'll be starting up, or we're hoping to do them every second Thursday of the month. And then we'll keep it on a cadence so that the community health workers will be able to know that that's the time that there's going to be some training done.
All right, thank you, Diane. We've got a couple more minutes and we've got some good questions. I want to try to get to these questions before we break. The first is from Suzanne. Is there a connection? This is for any one of you four. Is there a connection to the community navigators from the Health Benefits Exchange to help with insurance? Have you run into any of those navigators from the state-run benefits exchange, or is that something that you try to punt?
We're hoping to have that training provided to our community health workers. It's something that I need to work with the state to find out who is able to do that training for us. But that is definitely one that's on our list for the community health workers to receive the training on.
Okay. Any one of you four from Walla Walla want to try to answer Suzanne's question? Community navigators from the Health Benefit Exchange, do you ever deal with them or not?
I think Rachel as our community health worker lead, she's kind of in charge of the pack, and she probably has she's our most seasoned community health worker, has the most experience with Provider One and able to navigate that. She's our go-to girl.
So we pretty much just make a lot of phone calls until we get the right answer. We just find any kind of resource we can. We have found a couple people for Medicare set up with their booths, and then I get their number, and then we just pass it along, and we just stay really connected to our go-to numbers. I'm not even sure if it's directly from the Health Benefits Exchange. I just call every navigator I could find and be like, where can I send my people and how can you help? So I wish I could give you a more direct answer though, if it was from the Health Benefits.
Okay, but all three of you have had some experience talking to the navigators, either directly or indirectly?
Yes, and we do have, at Providence, we do have financial counselors, which we do have the benefit of referring that are linked into that. So there is a lot of referrals going that way as well.
Okay, but Brian still indicated that might be something, Brian, you would think community health workers could get a little more knowledge about before they step out into the field.
Yes, and I think that might just be for me because I like to know a lot of things, but I feel it just a little bit of education on insurance would be beneficial for the CHW, just so they know who to call, where to look, instead of when I first started making 50 phone calls, because we started during a pandemic, and then now it's 3 or 4 people that we know where to go and who to get the right answers to. So it's just, at the beginning would have been nice, but slowly working into it and understanding more of it.
Okay.
I want to
Okay,
add
last-
two. I'm sorry. I just want to add two things that I think are really important that, when you do kind of brave, bold things, you make a lot of mistakes, and I'm not afraid to admit them and learn from them. And one thing that I did make, and that we thought that this would, this is a mobile workforce. They work out of their car. They have a laptop and a backpack. I did not recognize the value of the connection and that they needed a place to call home. And so now they have offices and they have a place and they have a time that they can unite and problem solve and connect. So that was right out of the gate, go off into the world and do good work. So that is really important caveat that they do need a time to brief, to connect with their team and each other. So that's one thing. And the other thing that I also did not anticipate is the work is daunting and heart-wrenching and raw, and what they are seeing absolutely must need a time to debrief. So as co-workers, as leaders, as supervisors, the time that you need to check in and allow that open door policy of them just to come in, to yell, to scream, to cry, to process. When you walk in in a hotel room and see a client you love and work with that is dead, you need to process that. These guys are literally on the front line of life and death and healthcare. They're taking the brunt of everything. So those are just two really important caveats that I did not see coming, that when you build a program, you've got to build in.
All right, thanks so much, Becky. And Diane, I'm sure you're taking good notes on this one since you're on.
Yeah, so
for
Patrick, there's
GCACH.
one more question in the chat that if you could
I
do
saw
that
that.
one, and then maybe we can wrap up and take a break.
Yeah, so the last question in the chat was kind of for you, Becky, and that is, you mentioned this at the start of your slide presentation, but it's dealing with the ROI question for what you're doing. And so you've been able, just to reaffirm this, you've been able to show the people who deal with the numbers that this is giving a positive return to the Providence system.
Yeah, but it's over and over and it's over. It's just on repeat all the time, and I'm sure they're just tired of hearing it. But because we're on that dock. We have one foot on fee for service and production model, and we have one that we're going out to sea in a value base. So we're at that crossroads, but most of our value-based contracts are total cost of care, and we can't do total cost of care in brick and mortar. You need to be out on the ground and you need community-based workforce. So I'm going to continue to shape the argument and shape the case and show the numbers. The numbers are pretty significant when you see the clients and the patients that they work for before Brian, before Maria, before Rachel has come into their life, the utilization, the health outcomes, the burden on EMS, and then the direct stop, the data point, and then the drop. So I'm just going to continue to show that. So, but it's tricky because you still have people in, especially finance accounting, that live in that revenue volume, but we're going into a different world. So we just got to catch people up. So we're just going to continue to crank and over and over and over again, but I'm not giving up.
Yeah, don't be afraid of those people with the numbers, Becky. So
okay, I have you on speed dial. You may have to help me with that.
And Patrick, this is Suzanne. Can I ask just a really quick question of Becky?
Yeah, sure. Go ahead, Suzanne.
So, Becky, I'm pleased to hear that you made a visit to the HCA, and I'll catch up with you later to kind of find out who you talked to and what you talked about. But this is a great follow-up for us to talk with you about in terms of how some of these contracts might work at a high level. I know we can't go into a lot of detail, but how are they structured, especially on the value-based side? Because in my perspective, in watching this for 4 or 5 years now, the value-based side is the winner to support the services that you do, because it allows a tremendous amount of flexibility in how you create your programs. But I just want to hear a little bit about how those have been structured and how you're operationalizing them, so we can add that to our book of knowledge and think about how we might use some of the learnings you have for the future.
Yeah, and definitely let's connect Suzanne offline. I know we're wrapping up, but I just want to state two things. My message to the Healthcare Authority was really a 2.1. Let's start paying direct service for this vital workforce. and because they're decreasing healthcare expenditures and improving health
Right.
outcomes.
Right.
And the second is that let's start supporting community service organizations that address social determinants of health, because they're definitely impacting health. So let's
And-
start, leveraging Medicaid dollars to support community service organizations that help in that space. But yeah, and for the love of God, please, let's maybe do something different with MCOs, and instead of telephonic case management, that's very remote. We know that in medically and socially complex patients, this type of, when you call somebody to check on
Right.
them in a case these guys hold hands and accompany, they go to appointments and they go to grocery stores. This is the type of, you can't do this remotely and telephonic. You gotta do a new way of doing things. So we'll connect.
They're not fully substitutive ideas. So yeah, I'll look forward to talking with you a little bit so we can think about, as you know, there are tons of issues around working with the feds around how to structure this potential reimbursement model that we may create, and your help will be useful. Thank you.
Thank you.
All right, with that, we're going to have to say goodbye to this part of our Walla Walla presentation. So Becky, Maria, Rachel, and Brian, wonderful presentations. You can be reading some of the feedback in the chat box you've gotten, and I hope you'll stay in touch with the Greater Columbia community as we move into 2022 and beyond. We are now going to take a 10-minute break. We're running a little bit late, but we can make it up. We will reconvene at 10:20 with yet another voice from Walla Walla, and that's from the fire department, Cody, Maine. So stay tuned, and we'll be right back. 10:20. Please check in. All right, everyone, I hope you're finding your way back to your screens and seats, or if you're standing, to your standing place. And we will start here momentarily with a view from Walla Walla and the paramedicine program in the fire department that Cody Main will inform us about. So stay tuned. We'll be starting in just a few seconds. All right, Cody, greetings from the 9 counties of the Greater Columbia ACH, plus this particular county, plus I think we've got a couple people from Thurston County and Olympia on board, and maybe some from Seattle. So you've got quite the audience, and we're looking very much forward to the lessons learned and what has happened in the year that you've been at the helm of the paramedicine program in the fire department of Walla Walla. So the floor is yours, and I assume we have a PowerPoint or not?
Yes, sir, you do.
All right. So Stacy,
yeah.
are you running the show here for Cody, or is Cody controlling the screen?
I will
Yep.
share it right here.
All right, there you go.
All right. Are we up?
Yes, we are.
All right. So, well, thank you for the opportunity to present about the community paramedic program here in Walla Walla. I wrote some new material the last couple days, so I'm gonna. I tried it out last night at the local police department Citizen Academy. I had a couple people come up to me and ask for volunteer opportunities. So some people bought into my shtick, if you will, here. So, anyways, here we go. So my name's Cody Main. I was hired by the city of Walla Walla March 1st, 2007 is when the trajectory of the Walla Walla Fire Department changed. I've been here nearly 15 years. We started our community paramedic program on May 3rd of this last year. And it was a long time coming. Our administration had been looking into a community paramedic program for about 10 years. And, you know, it was just really hard with budgets, the recession that had happened, you know, 2009, 10, all that kind of stuff. So it really kind of got being put on the back burner. And municipalities don't really want to try new things unless it's with somebody else's money. And that's where Providence came along. They had grant money available to each of their service areas for community collaborative projects. And the great Becky Betts, she and I had met through a mental health first aid training, and somehow or another, I guess I impressed her somehow. I don't know. So anyways, so we formed a partnership. Providence gave us $110,000 to the city to try a year pilot program. We're currently in month 10 right now, and it's successful to the point that we're looking at growing. So, you know, so I always want to take the opportunity to thank you to Providence and Population Health and Becky for giving me the opportunity to, you know, just try something not necessarily new. You know, we're modeled after the Bellingham Fire Department's community paramedic program, but it's new to our area. The city of Walla Walla administration's been incredibly supportive. I've presented a couple times now at city council. All the city council members, the city manager, the deputy city manager, they're all incredibly supportive, and that's been great. The department's administration, we're doing good things here in our department. We were stagnant for a long time, but I'm excited about the new trajectory that our department's going on here. So, and then also the GCACH, I think that you guys really kind of set the table for us to do that with the community health workers program. So thank you for that. And I've been told I have the face for radio, so I'm sorry that you have to see me virtually. Last night was in person, so maybe they got a better show. Just real quick, a little bit more about me. I've been kind of working in this community realm for a while, not just as a paramedic, but there's some county work groups I've been a part of. Reach Out Walla Walla as a suicide prevention work group. Men in the Middle is focused on reducing stigma of mental health related problems. The primary victim of suicide in Walla Walla County is a middle-aged white man. So we're trying to just have conversations with men about mental health and really kind of break down that stigma. We had a psychologist that spoke during one of our meetings, and he said that women tend to relate face to face, meaning they talk. And he said men tend to relate shoulder to shoulder, meaning usually over a task. Men won't really sit down and have a heartfelt conversation. Some do, depending on your relationship, but most men don't, so they want to do something together. Let's go cut firewood, and then maybe the talk happens. Let's go fishing. Let me help you re-roof your house. Those types of things. I'm also a member of the Cross System Crisis Response Subcommittee. It's a subcommittee off of the House Bill 1477 bill, which is currently in the process. We've had, I think, 3 meetings now. There's 8 subcommittees that are off of that bill. One of the founding members of a first responder support group here in Walla Walla County. It's called the Brave. I had a meeting yesterday, and it was pretty awesome to have a group of first responders, police, fire, EMS people sitting around and talking about things. And that's been something that's been missing for a long time, I think, in public safety, is just peer support. So it's a growing thing. And then the last thing is community change team. It's a trauma-informed approach to substance use disorder and resiliency. So the community paramedic mission statement for the city of Walla Walla is to provide unique care and solutions for patients with unique needs. The thing I come back to, a unique need is, it's dependent on each person, and it's dependent to that specific time. A unique care and solution for somebody might just be a sandwich, at a given time. I take it for granted that I can go home and, I got food in my fridge that I can get to, or I have it here at the fire station, but some people just need that unique solution of a sandwich, or a bottle of water. There's other things that are unique. There's one gentleman here in town who I just kind of didn't really stumble across. He called 911 one day and said he needed somebody to talk to. And the dispatcher said, "Do you need a policeman?" "Nope." "Do you need an ambulance?" "Nope." And they're like, "Okay, well, how about we send this guy out to you?" So I went and spoke with this gentleman. He's an elderly guy that lives by himself. And over a series of meetings with him and everything, come to find out, this gentleman had been a veteran for 62 years. He didn't know it. He thought that he thought to be a veteran, you had to have served during combat, which he did not. So he had been discharged honorably from the military, lived in a community that has a VA facility right here, and never knew that he was entitled to care and benefits. To kind of go through that case real quickly, we stumbled onto what appeared to be some caregiver abuse, some financial exploitation and everything. This gentleman looks like he lives Social Security check to Social Security check. He actually has a large amount of money in his bank account, and he was being financially exploited by a longtime caregiver. His closest family member is in Northern California, and he had a son that was in Chile, so he didn't have anybody local. He's currently going through the court process right now of having guardianship put with him. So that's something that he wants too, which is a really good thing. So we've been able to create a barrier for that gentleman, in the sense, a good barrier where he's financially protected from somebody who was exploiting him at one point. That's not something I learned in medic school. So partnerships for better healthcare, as I said, Providence and the City of Walla Fire Department started this partnership. So we have the City of Walla itself, not just the fire department, but the city administrations behind it. Walla County has a 0.1% sales tax that goes towards behavioral health funds and issues. And they recently gave us a $50,000 grant from that behavioral health fund to help sustain our program. So the county is financially involved now too. And then one of the things I'm really proud of too, I'm a member of the International Association of Firefighters, Local 404, and the Walla Walla Professional Firefighters have a benevolent association that I'm the treasurer of, and a small portion of our guys' paycheck every month goes into the benevolent association, and that's money that they then allow us to use throughout the community to do things. And some of the things I've been able to do for patients out in the field in my role as a community paramedic has been funded by our union's benevolent association. So it's really cool to see members of our work group, you know, contributing and literally putting their money where their mouth is. So, and of course, the GCACH, I'm really excited to hear more and work with the different agencies as these community paramedic programs start to be developed and implemented throughout Southeast Washington. So the ABCDEs of community paramedicine program, the main one that came up is advocacy. You know, I've had to plead with some people, I've had to argue on behalf of other people. This is a huge thing. And I know that they talk about being a patient advocate in paramedic school, but it has not been probably a day in my role as a community paramedic where I haven't had to advocate for somebody. And I assume that probably some agencies around here, I've made their work a little harder. And then that's not necessarily a concern of mine. Mine is to go out and take care of people that I feel are being underserved and who don't have people, who don't have family, friends that can talk for them, you know. And one of the things that one of our lieutenants said is, you know, how can somebody at an agency go to their boss and say, you know, that kid at the fire department, you know what he made me do? He made me do my job. You know, that's not a legitimate argument that somebody can give to their boss. So advocacy is big. Benevolence, just the disposition to do good, being kind, compassion, dignity. I think that dignity, compassion, respect, all those things, they're currency out on the street. I think that living up to your word, being a compassionate person, maintaining people's dignity is huge. You know, a lot of people, they don't have the funds, right, to pay for a service, and they don't have to pay for mine, but being out on the street, the way I interact with people, it is a currency. It's a give and take. So, and then experienced, you know, a community paramedic is somebody that I think needs to have been in the community, people, someone who's experienced, who has a lot of, not necessarily life experience, that's important, but just experience with disease processes, treating people, knowing different resources throughout the community is very important. So I've been here 15 years, and I feel like that's been a substantial amount of time. Our new guy that's going to be starting, hopefully March 1st, I think he was hired here in 1876. So he'll be very well experienced. So the roles of a community paramedic, I'm a navigator. So point the way, you know, maybe not just point the way, but say, I know the way, you know, here, follow me. Or some people I can point. So a cut man, you know, this is a boxing term. I thought it sounded cooler than a cheerleader. So I went with cut man. You know, there's some people that just come to you. They've been in the ring for a while. They've been beat up by life. they're bruised, they're battered, they're bleeding, and they just need somebody in their corner that can kind of patch them up, staunch the bleeding, ice the swelling real quick, give them a few pointers, say, go get them, kid, and push them back out in the ring. And, you know that that person is going to be there at the end of the next round, right? So I went with cut man. I thought that was good. So, and then just patient advocacy. You need somebody that's going to roar on somebody's behalf. I did find, it took me a while to find a picture of a lion roaring with his eyes open. Most of them I found they were closed, and it just looked like the lion was yawning and tired. So anyways, but this is one thing that you need. You need somebody that's not afraid to make a little noise on behalf of some people who've been underserved for a long time. So my daily goals is meaningfully impact people's lives, show grace and respect to those in my care. It goes back to dignity here. Don't take anyone's dignity. They've probably already given it away. Simple solutions are generally the best solutions, and they're often the cheapest. There's one gentleman here in town who you have our local hospital. It's a nonprofit hospital, and then you have the government, the VA, who are, lack of a better term, kind of fighting back and forth as to who this patient belongs to. Well, as Becky will say, it belongs to the community, you know. So they're talking about long-term placement. Well, if you're somebody like myself, who's the boots on the ground, like Rachel, Brian, Maria, and you go and you watch this person live in the environment that he lives in, you can tell that he can't see. So one of the reasons that he might not be an independent person who can take care of his medical situations is because he can't see. So instead of talking about long-term placement, let's talk about just getting the guy an eye exam first. Does he simply need a pair of glasses? And that's one of the reasons he can't manage his diabetes and take his medication. It's because he can't see. Does he need, does he have cataracts? Need surgery for that? You know, those are all things that are fairly easy to correct and a lot cheaper than long-term placement. So looking for the simple solutions is generally a good place. Assist coworkers and solutions that can help reduce the daily stress. So our guys just recently went to 48-hour shifts with 96 hours off. You know, we have guys that are cycling through the ambulances and the fire trucks and everything. And that's 45 different people who can be called at any given time to go help one person. And so then you have 45 different people who are trying their best to figure out where to start with somebody. And they're doing that based upon their experience, their life experiences, morals, ethics, and all that stuff. So you could potentially have 45 different starting points for this person. And one of the things I can do is I can go meet with that person. I can come up with a starting point tailored towards that specific patient, and then I can put that information out to our guys, and everybody can have the same starting point. Build rapport and trust with uniquely challenging patients. That's one of the big things there. And then just do good. I get this from the gentleman at Camino Island, who's a community paramedic up there. I asked him if he could send me his protocols and his guidelines, and he said, man, I don't have any. My chief tells me to go out and do good. And I was like, okay, that's cool, I can do that. All right. So that's just kind of the daily goal. So program goals in general is to show that community paramedicine is a unique and meaningful form of medicine. Be an advocate for patients while balancing the stewardship of emergency resources and services. So I'm not only a provider in the community, but I'm also a taxpayer of the services that we use. You know, I'm somebody that has a family, and my family might need emergency services, whether it's an ambulance, fire truck, the emergency department, just like anybody else in the community. And I want to ensure that those resources are available to everybody when they truly need them. And not everybody is best served by an advanced life support ambulance or a trip to the emergency department. So really trying to advocate for people, get them into the right type of setting for their care while maintaining the availability of services for those that really need it is one of the primary thoughts that I have. So act as a pathway of information to Walla Fire Department members regarding local trends and frequent utilizers. So it kind of goes back to that care plan that I can disseminate the information out with in our department as to where you might start off with this person. You know, one of the things that I learned through talking with the police department is there's a local transient gentleman here in town who he sleeps with a homemade knife. He has a shank. You know, he's out of the penal system, and he just kind of has that attitude, that mentality ground into him, you know. So most of our guys are well-intentioned people, and we don't want to stand over somebody, yell, shake, maybe kick their foot a little bit to wake them up. So our guys were getting down and kind of rousing them, you know, nicely. Well, learning that this guy sleeps with a shank, right? That's important for our guys to know, because I don't want our guys to get stabbed, you know. So being able to talk to guys about local trends and individuals is really important. So act as a liaison between Walla Fire Department and local social services. So being a paramedic here for 15 years, I knew about all the different services in town, but I really didn't know exactly what they were, maybe what their specialty was, the people that they served, or how to even access them sometimes, or their hours of operation, you know. So one of the things I can do is I can help our guys understand where those services are better for people. So it's the next logical step in modernizing our fire department. The City of Walla Fire Department started in 1876. We've had 9 members die in the line of duty, and you know, we've modernized since then. And we no longer use horses to pull our fire engines to fires. You know, we no longer have old antiquated breathing apparatus. 85% of what we do in the Walla Fire Department is medical. You know, so the huge amount of work is on our ambulances. It's the next thing. And one of the interesting things about Walla too, it's the second oldest advanced life support service in the state of Washington. We were certified just minutes behind King County. So Walla County has been a leader in EMS, you know, literally since the beginning of EMS in Washington state. So advocacy for proper, ethical, moral health care for our most vulnerable adults. And, you know, I don't mind to jump in a boat and rock it if I think that somebody's being treated unethically, or, you know, the healthcare lacked morals or anything. You know, I think there's a couple boats I jumped in with a drill, and I'm not just rocking it. You know, like, I don't like the boat. The boat's an old rickety boat. Let's sink this boat and build a new one. There's a couple of the attitudes that I have. So provide an appropriate and agile response that more traditional EMS responses are not able to provide. And we'll touch on that a little bit here in a minute. So typically where I start with somebody is with Maslow. You know, if you've taken any kind of just entry-level psychology, you know, the person's need up to self-actualization is built on Maslow's hierarchy of needs. So the vast majority of people that I deal with are down at the foundation. You know, we need to start building that foundation. And I think you probably understood that too with Rachel and Brian and Maria talking. But, you know, air, water, food, shelter, sleep, clothing. I don't help out with the reproductive aspect. You know, that's something I leave to them. But anyways, I think that that's a really important way to go. And one of the things that you'll find me, I have a cooler in my rig, and I always have a bottle of water with me. A bottle of water is a super powerful tool. If I walk up to somebody on the street and I have a bottle of water in my hand and I give somebody a bottle of water, the first thing I'm doing is I'm showing them that I'm trying to help them, right? I'm trying to meet a very basic need of anybody. Shows that I care about somebody, I'm willing to help somebody. It's a non-threatening thing. So, you know, just a simple bottle of water is a very, very powerful tool. So Robin Williams, I think this is an important reminder. And this is one of the things that I keep in mind a lot. Everyone you meet is fighting the battle you know nothing about. Be kind, always. My neighbor, he's done some stand-up comedy stuff, and he has a great story about actually meeting Robin Williams that I just love hearing him talk about. So anyways, this guy was a gem. And I think it's one of those things where, you know, they said if you could have dinner with anybody that has passed away, who would it be? And I think I might pick Robin Williams. So traditional EMS versus mobile integrated health. So traditional EMS usually has 2 staff members. So time management tends to be quick and efficient. We get dispatched to a call, and we want to handle that call as quickly and as efficiently as we can so we can be ready for the next call. Sometimes that might come across as non-caring or not as compassionate as sometimes people would think that we should be. That's not the case. It's that we only have 2 ambulances that are serving the vast majority of Walla County. You know, so our guys, we hold ourselves to a high professional standard, and we want to be quick and efficient and professional. In Washington State, our ambulances are only limited to transporting to Providence St. Mary's emergency department. Our ambulance, if they receive a 911 call, they cannot transport anybody to a primary care physician. They can't transport anybody to urgent care, a clinic, anything like that. So we can only take them to the emergency department. So that really limits, you know, where people are, because a lot of times our ambulances end up being utilized as a taxi for people, which is just part of the problem. And, you know, I think one of the issues I see just in medicine in general, and this isn't a Walla Walla specific thing, but our society, if I can't drive to it easily, it's unobtainable, and I can't get to it. You know, we used to be a people who walked from Missouri to Oregon, and we will no longer walk 6 blocks to get medicine the vast majority of the time. So I would rather go without my medicine and have the high chance of a stroke, or have the high chance of my blood sugar, you know, getting high to the point where I get diabetic ketoacidosis because I couldn't get my medicine. Well, the pharmacy was 8 blocks away. Well, I didn't have a ride. So, you know, transportation, even a very small, a small physical distance, is still a huge barrier that we're getting to. And that's where I see mobile integrated health coming in a very powerful way. So our equipment, is expensive. So a Zoll cardiac monitor, for instance, is $39,000. An EMS ALS drug box, that's going to be several thousand after you put medication and equipment in it. So a Stryker power cot, that's another $25,000. So you compare that to mobile integrated health, and you have 1 staff member and a pair of socks. I hit that button early. So time management is not as sensitive. You know, I can have calls that are literally knock on the door, they're not here. People don't want to talk to me. It lasts 3 minutes, or I've been on scene with some people up to 3 hours. You know, so I don't have that time component where I'm looking for quick and efficient solutions. You know, I really want to spend time and delve into the problem as much as I can. So I can transport to secondary destinations such as urgent care. I can take people to primary care. I can take people to comprehensive health Waypoint Clinic. I've helped people to dental appointments. You know, instead of somebody going to the emergency department for dental pain, we've got them to a dentist. You know, so that all goes to those avoidable emergency department visits. So, and then inexpensive basic needs. So, such as a pair of socks, maybe a knit cap, a night at a hotel. These are things that our benevolent association has helped fund. Bottle of water, like I spoke about. So I carry freeze-dried camp meals with me that I can cook up and make somebody a meal if I need to. And the information you get from those people is amazing too. You know, when you start showing that you're going to care for somebody. And then gas. Sometimes people just need gas in their car so they can get themselves or their mom to the primary care appointment that they have in a half hour, but they don't have gas in their car. You know, it goes back to these simple solutions. They're generally the best and often the cheapest. So this is a picture of our mental health situation here in Walla Walla. So this was a photo taken by myself November of this year. There's a man laying under there. He is alive. He was just laying out in the cold for nearly 10 hours before anybody noticed him. After I spoke to him, I knew him well. I was able to identify this individual based on some very distinct facial tattoos and everything. I knew him very well. He was mildly hypothermic, but I felt I could treat him there on the scene rather than pick him up and take him to the emergency department. The reason I did that is because often crisis, from what I've been told and how I understand it, crisis needs to witness the crisis. So a designated crisis responder sometimes will say, well, I didn't witness the crisis, so how do I know they were a vulnerable adult? Well, here's the crisis, deal with it. So this gentleman, after this, he was indeed taken to the emergency department, and he was sent out of town on an involuntary treatment hold and was gone for a couple months. And I have recently heard he's back in town. I have yet to contact him, but I look forward to seeing him and how he's doing now compared to that moment in his life. So currently I'm seeing about 28 patients on my active caseload. The list is always evolving. You know, people will sometimes pass away, people will move out of the community, we get people placed into different facilities, and they no longer need me. My aim is to always just address somebody's barriers, and then hopefully remove them from my list and add somebody else. There's always somebody out there that needs more help. So 28 is what I found I can kind of handle professionally and compassionately without really sacrificing the service that I provide to them. So 50% of my patients tend to be acute and chronic, and the other 50% are mental health related. So specifically, schizophrenia and bipolar and substance use disorder are big issues here in town. So I go to private residences and unhoused individuals. So we started back in May. This is a little snapshot of the statistics here. So an MIH is a mobile integrated health visit. So in May, I did 18 visits. I was just under 41 minutes per visit, still accounted for 12 hours on scene. And that escalated fairly quickly up to October, where I got 89 contacts. So I finished the first 6 months with 309, which accounted for just under 173 hours. So through January, I've had 510 in that amount of time. 35 minutes on scene is usually what it takes, and I've been on scene with people just under 300 hours. So that 300 hours that I've been out on the street with people is 300 hours that ambulances have been available, fire trucks have been available. That's 300 hours of emergency department beds that are open. That's 300 hours that law enforcement officers were out on patrol rather than dealing with some of the issues that they would have maybe had to deal with had I not been there. So the effect is pretty far reaching. So return on investment to Providence. So as we're always looking for the avoidable ER visit. So $2,400 is what I've been told is the conservative estimate per ED version. And that's just a person showing up in the emergency department. Their name goes in the computer, they get placed in the emergency department, doctor sees them, that's no IV, no study, no form of imaging, no labs, no medicines, nothing, just $2,400. So that's what we're looking at as a conservative cost estimate. And I've had 108 avoidable ED diversions, which accounts for $259,000. So if you take away the original grant and Providence, their return on investment right now is sitting at $149,000. So goals. So want to get into some cardiac patient post-discharge follow-up, specifically around congestive heart failure, acute myocardial infarction discharges. So one of the things I think will be really good once we get our nurse practitioner up and running, that I'll have more access to a provider, will be point of care lab testing, which is an iStat. You know, this device that you can take just simple blood sample, and depending on the cartridge that you have in the device, you can get lab quality diagnostic results within minutes, you know, to the point where maybe we can treat somebody at their home based on the interpretation of the labs that I'm able to obtain and send to a provider, and then that provider can turn around and tell me what they want me to do with this patient. So that way we've kept an ambulance open, we've kept a person out of the emergency department, we've treated somebody at their home, and it's just a win-win for everybody. So community education programs are a big thing. Again, the gentleman in Camino Island that I've talked to, he has a class, it's called ACTS, Antidote, which centers around Narcan, how to get it, where to give it, when to give it, compressions. So compressions only for CPR. You know, people are more likely to do bystander CPR if they can only do the compressions. So, and compressions are the most important aspect of adequate CPR, because you're using the blood that was, or the oxygen that was already in somebody else's blood at the time of the cardiac event. So compressions and tourniquets. And the neat thing about this class is you can have somebody walk in that knows nothing about Narcan, nothing about compressions, nothing about tourniquets, and in an hour, based on the curriculum he has, they can leave with 3 life-saving skills. And that's just, I think, really cool, because a lot of people just in our day and age, we don't have time, you know, to take an 8-hour course. You know, as good as the first aid courses are, a lot of people just don't have that kind of time to do that, you know, versus being able to go to your local fire department, or this class can come to their place of work or community group, and in an hour you can teach this class. So this is one of the things I hope to put into our curriculum here as we pursue a formalized community risk reduction program in the city of Walla Walla. And what the missing component that we really have is adult education. We do really good with our SAM program, Safety Always Matters, which is just a fire safety curriculum that we have for kids. And we see every student in Walla Walla County from kindergarten to 5th grade, and the curriculum escalates over time. So we have a really good youth program, but we're lacking an adult program. So disease specific education. So, you know, I would like to get to the point where I can team up with specific navigators throughout the hospital, you know, whether that's an ortho navigator, a cardiac health navigator, diabetes educator. I know the Cancer Center has navigators. They have like a men's health navigator with prostate health. They have women's navigator for breast health and everything. So I think it'd be really good to bring specialized education, specific education to people, because a lot of people, they don't understand their medical literacy is not there. And we tend to talk to everybody like they're a peer, and they're not. And I've seen that many, many times over with paramedic students that ride at our department, where a paramedic student will read the book and then he'll go and he'll talk to a patient, and they'll say, do you have any cardiac problems, pulmonary problems, renal problems, endocrine problems? And they'll say, oh, no, I don't. And you say, okay, now ask them this way. Do you have any problems with your heart, your lungs, your kidneys, blood sugars, thyroid? Oh yeah, I got problems with all of those, you know. So really bringing more layman term education to people, I think, is really important. So another curriculum is Stop the Bleed, QPR, question, persuade, refer, suicide prevention. And then you heard the community health workers talking about mental health first aid. And USA Mental Health First Aid is just trying to do for mental health what the American Heart Association did with CPR and early defibrillation. So long-lasting injectable medications. This is something that Bellingham Fire Department does, where you have people who are prescribed antipsychotics, and these people aren't really capable of functioning independently in their life, but yet they have to get themselves to an appointment, and then they got to find their way to a pharmacy, and then they got to remember to take their medication. And you take a medication such as Invega. Invega is a medication where you take an oral tab. Well, to stay properly medicated, you have to take it 365 days, once a day, right? So how many trips to a pharmacy is that for somebody, right, to get their refills? That's a lot, right? And you can actually go through injectable medications now, and you can go from 365 pills that you have to remember to take to Invega shots, once a month or quarterly or even every 6 months. So you can literally take somebody from remembering to take 365 pills to helping facilitate them getting 2 shots a year and staying properly medicated over the year. And we gave, when I went and rode in Bellingham, we gave a lady a shot of Invega, and the community paramedic said, if we did not give her this shot, spend 15 minutes ensuring that she got this shot, she would produce probably somewhere between 25 and 50 911 and emergency department visits. And that doesn't include how many just behavioral health disturbances she might be creating out in the community where the police are in contact with her too. So it was well worth it, well in the interest of the city of Bellingham to facilitate her getting her shots and staying properly medicated. So future growth, we have a second community paramedic starting, hopefully March 1st. Have a community health worker. One of the existing community health workers with Providence is going to be embedded within the fire department, which will be great. There's currently some talk right now about a co-responder. It sounds like this county, Walla County, has received some grant money, and I'm not exactly who it's from, but it sounds like it's $100,000 per year for 2 years to bring on a master level mental health worker, mental health professional, social work type person. And there's currently discussion amongst the city as to where that person is going to be located. Are they best served within law enforcement? Or are they best served within fire? We don't know. But anyways, that's another place of future growth. And then, of course, the 8 new community paramedic programs that the GCACH is looking at funding throughout Southeast Washington. So I think community paramedicine and mobile integrated health systems is definitely growing, and a much needed and very exciting trend coming to us. So community paramedicine is only limited by imagination, and this is my dream. I want to have a service dog. I think it'd be great to have a service dog. Dogs were at one point a traditional aspect of the fire service, and I think it'd be fantastic to return dogs into the fire service in a scientific-based therapeutic way. And when I pitched this to the city council, I said, we're in Walla Walla, so I said, let me introduce you to Sir Walter Shawa. Shawa being the city manager's last name, and I said his name will be Wally. We'll go with Wally. So that's a dream for me. But I got to thinking, and you take this photo and you couple it with the gentleman laying on the sidewalk under my turnout coat, and I mean, if you could just whistle at your dog and, hey, Wally, cuddle, and down he goes, providing warmth, a little bit of companionship. I mean, that'd be super cool. So elimination is limited only by funding. So I think the GCACH for that. And then I'd like you to read this quote real quick and then see if somebody knows what it's from. So, has anybody got it?
Can't say I do.
All right. It's Patch Adams.
Oh,
So that's just kind of the form of medicine that I've long thought was needing to be brought to the streets, and Becky said that I would say it, and I don't want to prove her wrong. But for the longest time, I think we've thought in medicine that the best medicine comes out of a vial or a pill, and it doesn't. You know, I think there are those medicines, and there are times where people need that type of medicine, but I think everybody needs some compassion. They need you know, some meaningful conversation. They need maybe a cup of coffee. You know, they need that cup man or that lion or the navigator, and I think that's what we're aiming to do here in Walla Walla. So, any questions?
All right, Cody, thank you so much. We have time for just a couple of questions because we want to leave enough time for Martine Sanchez to report out on the BART clinic. But I've seen some wonderful comments in the chat box, Cody. So great job. I think we all learned a lot, and more than that, it was very inspiring. Do we have a question that I could take out of the chat box? It doesn't look like it. Anybody?
I saw one about referrals.
Oh, that was it. Yeah. Why don't you take that referral question?
Yeah. So every morning I come in. I have a work cell phone. We have a program on my work phone. It's called Active 911. So it catches all of our dispatches. So every morning I come in, I go through all the alerts on my phone, and I'll start to see reoccurring addresses, or I'll see addresses that I know have been a pattern for quite a while. And so I'll start there, kind of go through and see that. And then I have access to Epic through the hospital, which is a really important aspect to a community paramedic program, is having access to information and being able to collaborate between other providers. So I can look and see who's admitted, who's been visiting the hospital. And then I can cross-reference all that with the fire department's electronic health records. So I kind of do my own investigation and look for some patterns, and I'll find quite a few people that way. And then I do get referrals from the emergency department, case management people, pop health, through the community health workers, the RNs through there. Dispatch will get a hold of me. We've set up a deal for the police officers to get a hold of me if they run into some sort of a concerning issue for somebody when it comes to health or kind of the social aspect of things. So there's a wide variety. And then we also have a referral sheet set up for our guys when they go out in the field and they see something, they can fill out a referral and give it to me. So.
All right, thank you for those responses. Any other questions? Okay, here's a question from the Tri-Cities. Who at Greater Columbia is most involved with this? Who wants to speak up from staff at Greater Columbia? Who's most involved with this for John Christensen?
Diane can actually speak on the community paramedicine side or the community health worker side. I can say that we're just now starting with the EMS side. We're calling it EMSI, the Emergency Medical Services Innovated, and we have not announced truly who is going to be a part of that cohort, so it's just in the infancy stages of that, but definitely looking at rural communities and working with Walla Walla to see how we can scale out this program that absolutely has just insightfully changed Walla Walla. And I was having that conversation with Cody not too long ago about how Walla Walla was truly having some financial issues, and it really has turned that community around. So, you know, kudos to Becky and her team and Cody.
All right, thank you, Sam.
You're welcome.
And we're hoping to merge the two programs together. So with the community health worker and the EMSI project, we're totally wanting to merge those together. So really hope that yeah, and also we have the same example. We have so the Pasco Fire has a community health worker working for them through our program. They're actually contracted with Consistent Care, which Consistent Care is contracted with the fire department. So I think that these two lines of services, the community health worker and the MC project, they're perfect together. I think that it makes all the sense for them to be working together.
Exactly. And Cody also has 2 of his community health workers that are currently going through the EMT training and should be graduating pretty soon. So yeah, it's just tremendous that the capacity and looking at the scope of their skill sets and again, how Cody was explaining those hours, how many hours are taken away from, you know, true emergencies where you could actually be giving better care to the patient in both aspects. So definitely, we're excited to work with, you know, our community, our Greater Columbia region, and hopefully we can, if not, really duplicate those efforts, find the resources that we need for each one of those communities, those counties.
All right. Well, I think we're going to have to reluctantly say thank you and goodbye to Cody's presentation. Cody, that was, as you heard in the chat, very inspiring, and hope we can circle back with you in a year or so to see what year 2 has meant for your program and more nuggets of wisdom that you might want to pass on to the group.
Yeah, no, I think
So
that that's great. I look forward to it. I think one thing I'd like to say just real quick, I was able to teach this last night at the police department, and you never know who's in your audience listening. Congresswoman McMorris Rogers' local staff member was in the class, and he came up to me and said, "Hey, I'd like to meet with you. When can you talk?" And I said, "Whenever you got time, man." And he's going to be at the station today, you know, so you know, and we're having some issues with the VA and how they're treating some veterans, and it's not living up to the professional standard, I think. And, you know, I think having somebody like that it's a big deal. So being able to talk and seize those opportunities is important.
Great. All right, we're going to leave Walla Walla and move west for the last few minutes of our session and hear from Bart Clinic, not from a employee of Bart Clinic, but it's going to be presented by our own Martine Sanchez. So Martine, I think the floor is yours for the next 15 minutes.
Thank you, Patrick. And then I'll be sharing my screen with you guys as well. So Lindsay Underwood from Bart Clinic couldn't be here today. She's actually on vacation. She's on a flight right now as we're speaking. So, you know, I'm more than happy to present on their behalf. And so she wrote this, you know, article or letter so I can present to you guys. And it's just, you know, really highlights, you know, what Becky and her team have talked about social determinants of health, you know, getting people just, you know, simple things, you know, food, water, shelter that, you know, just helps people's lives. So here we go. Hello, GCACH. My favorite program to talk about is our community health worker program. What an invaluable tool this has been for Bart Clinic. Our community health worker program has by far exceeded our expectations. We are now helping with food, clothing, toiletries, rental assistance, and so much more. Some of the job duties for our CHW include assisting with inpatient transportation, collecting all social determinants of health sheets, and contacting each patient in need and offer some form of assistance, helping patients get on Medicaid, assisting with clothing, housing, and utility crisis, assisting with bus passes, people for people, and compass, tracking our patients in need and keeping meticulous notes and spreadsheets. There is so much more to do on the smaller scale. In considering the community health worker funds and what they are for, we have chosen to use them in a lot of different ways. The first being that Bart Clinic will assist people with 1 month's rent and deposit to a clean and sober house of their choosing, so long as they meet the income requirements and or need emergency housing. This has been a huge benefit to our patients. An example of this is patient B. Patient B lives on a very minimal Social Security disability check monthly. She has been living at Camp Hopes indoor housing and is thriving there. Unfortunately, she recently found out she has a rare form of diabetes that is life-threatening. She must eat 0 carbs and can only eat very few healthy items. Unfortunately, with the change in diet and other factors in her life, she could no longer afford to stay in the indoor housing and eat at the same time. We heard of patient B's situation, and our community health worker offered to pay her rent and help show her some budgeting techniques to be able to continue to support herself. Patient B will be attending our brand new Evelyn Ann Center, where she will get budgeting help and do some diabetes education. We have volunteers that are willing to do training in all of these areas. Patient D is another example of our community resources in action. With the assistance of placement in Oxford, some clothes that would fit him, Patient D was able to find a part-time job to be able to continue in our clean and sober living by paying his own way. Patient D also needed assistance with primary care. He struggled with follow through. So with our community health workers vigilance, she was able to find out that patient D struggles with reading and was able to help him complete his paperwork. Patient D is attending our Evelyn Ann Center, where he gets personalized help with reading and writing, along with basic computer skills and knowledge. Patient D has completely turned his life around thus far, and we look forward to seeing him continue to grow. Evelyn Ann Center is now a huge part of our efforts with our community health worker. Jim Barth has always had a dream of helping our patients to better themselves in all areas of life. We are now going to be assisting patients with the life skills they need to thrive, not only in recovery, but in life itself. We have now started a clothing boutique for our patients. In this boutique, patients can come get clothing they need with no strings attached. We are really going for the vibe of dress for success, and have found a lot of men and women to donate business professional, office casual, and daily casual. We are so excited to offer this for our patients. So many have arrived with no more than a bag of personal effects, and we are wanting to change that. Another feature that we'll add to the boutique will be shampoo / conditioner, soap, feminine products, fingernail clippers, etc. We have found budgeting these basics ideas into our community health worker plan are simple, sustainable, and really use the best of our resources. We would love to be able to offer even more services for our clientele, which consists of primarily low-income households. Some of the various resources we use are Consistent Care, Compass, People for People, 211, OIC, food banks, St. Vincent de Paul's, multiple churches in the area, and so many more. A sad day for us was recently when Billy, our community health worker, decided to move away. Normally, I would say this would be because for grave concern, but due to how popular this program has been in our clinic, we had already hired a second person for the job months ago. She already knew the ropes when Billy left and is signed up for the courses. We are excited to add Michelle to our community health worker team. Her SUDPT will come in handy during many of the situations that arise while finding patients' assistance. We also have another person lined up to be her teammate. She has also signed up for the community health worker courses through Department of Health. Susan is a veteran in the field of life with vast experience with the Union Gospel Mission. With long-term recovery under her belt and years of past struggles, Susan knows what it feels like to be where our patients with the most struggles have been, and she is ecstatic to be able to give back to her community. As you can see here at Barth Clinic, we strive to help our patients in every area of life, not just addiction. We believe the more we can do to help them succeed, the better chances they will have at not only in recovery, but life itself. We would really like to emphasize that Barth Clinics subscribes to the philosophy of a hand up, not a hand out. We believe this is the most dignified approach to health and healing. Thank you, Martin, for reading this for me. I really wish I could be there with you all, but I just so happen to be on a plane right now, headed on a little break. If anyone has any questions about any of our programs here at Barth Clinic, please feel free to reach out to me. I will be back Tuesday after President's Day. Have a wonderful holiday weekend, everyone, and I look forward to our next meeting. Sincerely, Lindsay Underwood. She is the Practice Transformation Manager at Barth Clinic. And one thing to add, the patient D that she was talking about, needing to learn, how to read. I was talking to Lindsay, and she let me know that she so happened to be working at the front desk because of staffing shortages. When on a day that this patient came, And, he got familiar with her. She got familiar with him. She found out, hey, he needs help with reading. And Lindsay is personally teaching him how to read. He goes to Barth, to get reading lessons from Lindsay. At Barth Clinic, they have computer access for their clients, for those that need, help finding jobs or creating a resume, finding resources out in the community. So they're looking more into the social determinants of health. And Billy, their previous community health worker, she was also one of their patients at one point, and she got hired to work with them. She got involved as a community health worker, and she was doing an awesome job. And unfortunately, they lost her. But they have done a really wonderful job with practice transformation, implementing the community health workers into the care settings. And I would encourage you all, if you have any clothes, toiletries, anything that can be donated to Barth. If you happen to be in Yakima, passing through Yakima, please feel free to drop off any of those items. They're greatly in need. And thank you all for listening to me read Lindsay's letter.
Thank you, Martine, for reading that letter. Any questions of Martine about the Barth Clinic's experience with community health workers?
And the name Evelyn Ann, that's Jim's mom's name. So he's doing that in honor of his mom.
Okay. Martine, just for the overall background of the experience with the Barth Clinic, how long have they had their community health worker program up and running?
They were part of the first cohort that Diane started.
Yeah, since July.
Mm-hmm. So almost a year, and they've had good success with her being the community health worker there.
Okay. For those of you who are still on the line, I just wanted to pose the question, do your organizations, if you don't have community health workers in them, are you contemplating making room in your business plans, in your budgets over the next year or two to build in this new professional in our lives in Greater Columbia? I'm trying to find out, as I started the session with, where all of these 3,100 people work, and they've got to be in many of your organizations, and perhaps if they're not, they will be. So you might want to think about that. And Diane, you're helping to coordinate this Greater Columbia support, and do you want to say anything more about what we've done with community health worker support?
I just wanted to stress that I'm really thankful for our provider organizations and doing such amazing work around their communities. And I wish we had so much money that we could help you guys hire more and more people to do this work. But we do what we can, and we're hoping that, the organizations will be able to sustain these positions as we're going forward and be able to validate the need for them in their organizations, not only by, the return on investment, but really the return on investment into our community and how much it really helps our community and helps our patients as we reach upstream and help the patients that are in need because of their social determinants of health. But I really appreciate everybody being here today. We have had a fantastic amount of people that have been on, and we do value your time with us, and we are so thankful for you guys joining us today.
Thank you, Diane. And I'm gonna I don't see any comments or people raising their hands say that their organizations have community health workers with them. So hopefully we can circle back and know a little bit more and maybe report out at one of our future meetings. I want to turn the meeting over at the end to Sharon Brown, our new ED. But before I do, I just wanted to point out that we've just ended the 2-week celebration of Chinese or Lunar New Year. And if you don't know, this is the Year of the Tiger. And if you didn't know that, or if you don't know that Year of the Tiger is one that celebrates boldness and innovation and fearlessness. And to some degree, that's what we're doing here at Greater Columbia ACH as we look to 2022 and then 2023 is, I think, trying to be as bold as we can in healthcare reform for Southern and Southeastern Washington. So stay tuned and we'll track progress in the Year of the Tiger with future LC meetings. So Sharon, any last comments for the good of the order?
Thank you, Patrick. I may be the only thing that's standing between people and their lunch. So I will be extremely brief and say thank you all for attending. We had an overwhelming amount of attendees on this today, over 100 participants. We're really excited because that's how we move forward together when we all work together. And it was very inspiring to hear the stories that we heard and the good work that's being done in the community. And we can get there as we work together. Thank you, everyone.
All right, and with that, thank you to all the presenters, and we'll see you in our next meeting, which is mid-March. You see there the 17th. Please take that survey. It helps as we spend quite a bit of time as a staff trying to bring you the best possible programs we can. So please give us some feedback, how we're doing, how we can improve. And with that, have a great holiday weekend.